Let me take a moment to introduce our guest speaker. So Sanda Mesics is a true pioneer. After socially and medically transitioning in the early 70s, she became very active in the trans and LGBTQ community, including acting as a publisher of Image magazine and as an editor for Neptune Publications, where she got to rub elbows with many icons of the LGBTQ movement back in its infancy, as she documented the goings-on at the time. In fact, she, along with Virginia Prince, is credited with being one of the first two people to actually use the term transgender. So she actually helped coin that term. After her time in Philadelphia and working as an editor and publisher, she moved to Florida, where she pursued a medical career and started a nonprofit organization that served people who were suffering from HIV and AIDS, and went to nursing school, became a nurse midwife and a registered nurse and an instructor. She moved back to Pennsylvania and became the director of the St. Luke's School of Nursing. And in between all of that, she became a member of the World Professional Association for Transgender Health and expanded her teaching credentials by writing continuing education programs for practitioners who were seeking to provide affirming care for trans folk. She's, as I said, a certified nurse midwife, a registered nurse. She holds a master's degree in nursing and recently received an honorary doctorate from the University of Sciences in honor of her great contributions. She recently entered a well-deserved retirement after serving as St. Luke's University Hospital Network's Manager of Diversity and Inclusion. But I will say that I'm keeping her busy because she is a member of our board of directors. And so I want to thank her in advance for putting up with me and for what I'm sure is going to be a informative and valuable session. So with that, I'll turn it over to you, Sanda. Welcome.
Thanks, Corinne. That's sweet. I think you are one of the toughest bosses I ever worked for. You keep me on my toes. There's no.
And I don't even pay you.
That's the best part, isn't it?
It is.
So I guess we can go ahead and share my screen. And boy, that introduction made me feel old. Well, I am old, but you know, are we good?
Yep. We can see it.
So there we go. So this is all stuff that Corinne covered in her introduction, her very kind introduction. I started my own medical transition in 1972. So when you think about it, that's almost 50 years ago. And you know, 50 years ago, it was, you know, a lot of us were in the position of educating our providers. And that's where I sort of got very comfortable in introducing my healthcare providers into trans care. And so taking it forward, I think we're in a much better place today. And I think we are blessed with many providers who are very knowledgeable. But my job tonight is to make you a little bit more knowledgeable about feminizing care. So we're going to talk about this. And when we think about feminizing therapies, there's three main therapies that are used: estrogen, testosterone blockers, and progesterones. And we're going to discuss each of these in a little bit more depth, focusing on their effects, as well as any health considerations relating to these therapies. And these health considerations might include things like pre-existing conditions that could affect what is prescribed, or side effects or health concerns caused by these substances. Starting medical transition is an exciting time. And in fact, those of you that have done it probably remember that day as sort of a hallmark day in your life. You're going to start to experience bodily changes and what will feel kind of like a second puberty coming on. But I want you to keep in mind that it's important to remember that the extent and the rate at which these changes take place depends on many factors, including your age, your genetics, and your general health. So when I talk about these medications, I'm not going to talk specifically about dosages. Everybody's body reacts differently to these medications. So the medicines and dosages vary from those of your friends or what you might have read on social media. They're different. but I will give you some parameters to go by. But always have a good relationship with your provider. Don't be afraid to listen to their suggestions, but don't be afraid to voice your own suggestions and concerns, because really it is kind of a teamwork between you and your provider. And be patient. Sometimes it takes years for the full effect of this therapy to be seen. So I'm going to talk about what kind of providers provide feminizing therapies. Typically physicians, okay? So those can include endocrinologists, family medicine docs, internal medicine docs, OBGYNs, almost any specialty. When I talk to physicians, I introduce trans care as saying it's not rocket science. And then also don't forget, some nurse practitioners, physician assistants, and even nurse midwives are doing this type of care. And when we talk about accessing therapy, we sort of have to look at the WPATH standards of care versus the informed consent model of care. So providers usually use one or the other, and I'll touch on their differences. So WPATH is the World Professional Association for Transgender Health. They periodically publish the standards of care, which are evidence-based and kind of come by consensus. They're in their 7th edition, and we're working on the 8th edition as we speak. Under these guidelines, hormone therapy can be initiated only after a letter from a healthcare provider. And that healthcare provider is supposed to document that you do indeed have a persistent, well-documented history of gender dysphoria or gender discomfort, if you will. You have the capacity to make a fully informed decision and to consent for treatment. And that if any other significant medical or mental concerns you might have are well controlled. So those 3 factors are most important. On the other hand, an informed consent model is you working directly with the provider. You must have the capacity to make the decision. The medical provider has the responsibility to explain to you what the benefits and risks of any therapy is, the likelihood of any complications or side effects. You must be able to comprehend that relevant information, and you must voluntarily give consent for treatment without coercion or duress. So either way, when you commence therapy, feminizing therapy, the first thing that there will probably be done, aside from a history and physical exam, are baseline labs. So some blood work, usually a complete blood count, liver profile, renal profile, lipids, sometimes even prolactin and glucose. And we'll talk a little bit more about these as we go along. So when we think about it, estrogen is the biggie here. It's the hormone responsible for most of the physical and emotional changes we need to transition. The oral form of the medication is convenient, it's relatively inexpensive, and it's effective. So overall, providers like to start at lower doses and continue increasing the dose gradually, which kind of promotes optimum breast development. And we're talking about maybe starting at 2 milligrams a day and then increasing it to 6 or 8 milligrams a day. Oral estradiol is a safe medication, and for instance, Estrace is the brand name of one of these. We want you to avoid ethinyl estradiol. This is the hormone that kind of puts you at risk for blood clots, and we'll talk about that a little bit more. There's another form of estrogen that's available, and that's conjugated estrogens. And the brand name for that, there's only one in that class as far as I know, and that's Premarin. And Premarin, we usually start at about 2.5 milligrams a day. It's very inexpensive, but some people object to using Premarin because it's actually made from the urine of pregnant mares. And some people object to using horses for that reason. I don't think they're harmed in this in any way, but it gives some people the heebie-jeebies, and they don't want to go that way. But the other caution between the conjugated estrogens and the ethinyl estradiol is that these can't be measured when your labs are drawn. So you can be taking a ton of it and it won't show up on your labs because of the chemical composition of it. So a lot of providers don't like these either. So please, please, please never take somebody's birth control pills thinking you're getting the right kind of and the right amount of estrogen to be effective. It takes a little bit of time to get to a therapeutic level when you're taking oral medication. It takes day after day after day, and eventually that serum level gets to the point where you're metabolizing it and excreting it at the same rate at which you're getting it. So you have a steady state of it in your bloodstream, and that's where you want to be. The good thing about oral medication is that if you skip a dose or two, there's no big deal. You're not going to suddenly masculinize and everything will be undone. That's not true. There's enough there. You can go off of it for quite a while before you'll notice any ill effects. Safety concerns, again, those over the age of 35 and for smokers or nicotine users because of the increased risk of blood clots. And I want to touch on something that'll probably make your head kind of want to explode. And Corinne, you're going to have to forgive me for this, but this is kind of an important concept. It's called the first pass effect. And what this means is that anytime you take a medication by mouth, and you swallow it and it goes into your GI system, a good part of that medication goes right to the liver through the portal vein. And the liver, what it does is it breaks it down and gives it to the kidney to excrete. So that medication is not used at all. The other part of it is what actually gets into your bloodstream. So why is that important? It's important if you have any hepatic liver problems because your liver is working overtime to process this. And there's ways of avoiding the first pass effect, and that's other ways of taking the medicine. We'll talk about that in a second. So injectables. Injectable estrogen avoids that first pass effect. When you inject that into the muscle, 100% of that medication gets into your bloodstream before it goes to the liver and starts to get processed. So the effect is more quick. It's a quicker onset and a higher level. Gets into the bloodstream like within hours. The medication of choice there is estradiol valerate or deleestrogen or estradiol cypionate, or I always mispronounce that, cypionate, which is depo-estradiol. The estradiol valerate is usually given at about 20 to 40 milligrams every 2 weeks. The other one, 2 to 5 milligrams every 2 weeks. It's effective and powerful, but the problem with injectable estrogen is that you get peaks and troughs of the medication in your system. So when you inject, you're at a peak for a while, your body begins to metabolize it and excrete it, you get into a trough, then the next injection brings you back up to a peak again. And it's kind of hard to regulate this. So these highs and lows can cause mood swings sometimes, anxiety, weight gain, hot flashes, and migraine headaches even at times. These medications should be started at a low dose and with an understanding that these uncomfortable side effects are a possibility. If you're prescribed this, your provider will teach you how to self-administer injections, or alternatively, if you can't handle that and don't have anybody to help you with it, you could return to the provider every couple of weeks for a nurse visit and get injected. But most people handle the injections pretty well. Patches are another form of delivery that avoids the first pass effect. And we're talking here again about estradiol, and the brand names might be something like Climera, Allura, Vivell, and they're usually dosed at 0.1 to 0.2 milligrams a day. And we usually change the patches about twice a week. Some folks love patches, other people hate them. They can be very effective and very safe. Again, this medication gets right into your bloodstream before it's metabolized largely by the liver. But you should keep in mind that they have to be worn at all times, including while swimming, bathing, or even being intimate. And some users have reported that it can irritate the skin. I used them for quite a while, and I used to get these like fur rings around it was really gross and disgusting, but it does work.
Yep.
I'm not
so Sandy, before we jump ahead, we had somebody who got in just a couple minutes late, and if you could recap what the first pass effect is again, that would be helpful.
Sure. So when we take any medication by mouth, you swallow a pill. Part of that medication goes directly from your bloodstream, not in your bloodstream, it goes directly from your GI tract into the liver. And when it gets to the liver, it's actually deactivated. So it's metabolized by the liver and broken down into a form in which the kidneys can excrete it. So with a pill, a good portion of that dosage never makes it into your bloodstream to do its work. But what it does do is it kind of hammers at your liver because your liver is processing this. Kind of like drinking a lot of alcohol. The liver is working to detoxify and eliminate this. So to avoid first pass effect, you take the medication in almost any other form, injectable, sublingual under the tongue, rectally, or by injection. And that avoids that effect.
So while you just mentioned sublingual, so my understanding is that oral medication, the oral medication for estrogen, if you let it dissolve under your tongue, some people say that it can be very helpful. Other people I've heard is that the medication is not micronized, so it's not designed to be used sublingually, and that really all you do is just you end up swallowing it normally. So can you maybe give a little clarity on that?
Well, you're 100% accurate on that, Corinne. We should always use medications in the form that they're prescribed. And you know, I'm not saying that just because, you know, I'm citing on the side of medicine. Right now on the internet, on social media, there's this whole thing about rectal progesterone, where we're taking a pill that's meant to be dissolved in the GI tract and putting it in the rectum overnight. And, you know, people swear that this is the best way to get this medication. But if it's not formulated to be delivered that way, as you said, Corinne, you're just, you know, you're swallowing it. Whatever good it is actually going, you know, at a different rate. So I don't recommend it. But again, if you can find the literature that supports that, bring it to your provider and say, why can't I have this sublingually? Even a pharmacist can help you with that question. So
if you do let your oral estrogen dissolve under your tongue, I mean, in the end, you're going to swallow it anyway.
Right. So you're basically not wasting it by doing that, but the benefit you're getting from it is most likely had you just swallowed it with a glass of water.
Okay, great.
So, we're talking about transdermal. So, you should know that you can achieve the maximum effect with estrogen with relatively small doses. And what I always tell providers when I'm teaching them this, I say, start low and go slow. We hate to hear that because we want changes overnight. Taking higher doses doesn't make the physical changes happen any quicker. And in fact, it could even endanger your health. Because again, your body is working very hard. Once the estrogen or any medication for that matter reaches your bloodstream and attaches to the blood cells at the attachment points, the receptors, all the rest, the receptors are occupied, so you can't absorb any more into the bloodstream, and it's just passed out as waste. So taking more and more, doubling your doses, it's not going to work. And you're likely going to, you know, be hurting your liver in the long run. So don't do that, please. The good news is that no matter the dose or the type of feminizing therapy that you use, your healthcare provider will periodically check your liver functions, your cholesterol, your CBC, and they're going to, you know, monitor the progress in making sure that you're not hurting your liver or kidneys by processing the drugs. So, you can expect to have labs drawn at a minimum every 6 months. And at the beginning, maybe even every 3 months, or every time the dosage is changed, just to see the effect. You know, I'm going to take a minute here to kind of back up and talk about lab results. I also tell the providers when I'm teaching them, don't base your therapy solely on what those numbers are. The estrogen is this, the testosterone is that. That's a part of the picture. The other part of the picture is what you tell your provider. You're getting an effect, you're not getting an effect. You're getting side effects, you're not getting side effects. So once you put that all together, there's a lot of leeway in there. So that's why it's really important to have a dialogue with your provider, because I tell them all the time, do not treat by laboratory levels alone. Those are meant to keep everybody safe.
Yeah, so everybody's body is different, and everybody's body reacts to these medications in a different way. And so it's important that you don't just allow that lab work to speak for you. You need to speak for you. So if you're getting breast development, you want to talk about that. If you're not getting breast development, you want to talk about that. If you're getting mood swings, you need to talk about those things because they can obviously interfere with other aspects of your life, whether it's work or at home. And so if you're talking about those things, your provider can help you navigate potentially to different types of medications to help you through those challenges.
True. So the other medication that we're going to talk about are testosterone blockers. And there's some controversy as far as those are concerned, but we'll go over that as we go along. So there's a number of medications that can either block the estrogen or they can block the action of testosterone in your body or even block its production. And the medications in this class work a little bit differently from each other, and we'll go into that in more detail. The important thing about testosterone blockers is they come with a whole bunch of side effects. So this is what we want to be careful about. So the most commonly used one in the United States is spironolactone or spironolactone, however you want to pronounce it. It's effective, it's low cost, and it's probably the most commonly prescribed. But spironolactone is actually a potassium-sparing diuretic. So it's not meant for trans people, but they found out when they put men on it, they got feminized because it was blocking testosterone as kind of a side effect. So this is what we call an off-label use for a medication. It's not a great potassium-sparing diuretic. In fact, it's not prescribed a lot anymore. It's considered a crappy medication for that, and there's a whole lot of better ones. But a side effect of Spiro is that it inhibits testosterone secretion and keeps testosterone from binding to the receptors on the cells. So we call it an antagonist. They fight for that receptor site on your cell, and usually this spironolactone wins. The testosterone gets pushed out of your system before it can have masculizing effects. So taken orally, it can cause you to urinate excessively. It can make you feel dizzy or lightheaded because you're losing so much fluid. So drink plenty of water and fluids with this medications. Usually we start with a dose of 25 to 50 milligrams a day. You can go up to about 200 milligrams a day, depending on side effects and effect. The use of spironolactone can be dangerous for people with kidney problems because the kidney is what excretes it. So if the kidney can't excrete it, it just builds up to toxic levels over time. It can also have an adverse effect with other blood pressure medications. So again, it's really important for you to share your medical history with your provider, what medications you're on, et cetera, et cetera. Very important.
I know that for me, when I was on Sparrow, that I guess a side effect is that I craved salt, right? Because I was losing so much fluid. And so, I could easily go through a bag of potato chips a day if I, decided to put my mind to it. But maybe are there other side effects? So like somebody put in the chat here that it made them itch.
It can very well do that, sure. But think about it. If you're depleting fluids, your skin might get dry, prone to itching. Provided you're not like your throat isn't tightening, it's not an anaphylactic kind of reaction, but people have been known to itch from it. Some people can get hives from that and other medications as well. So they call it a potassium-sparing diuretic because while it helps you pee and excrete a whole bunch of stuff, it holds on to potassium. And in some cases, that's desirable. Not in our case, but in some cases it is. But the problem is potassium in large amounts stops the heart. And in fact, potassium is one of the things that they use in a lethal injection because it will stop that. So the danger is that, your potassium levels creep up over time to the point where you can start having heart arrhythmias. And so again, How do we monitor that? You keep peeing, you keep hydrating as well as you can, and routine laboratory monitoring, especially potassium levels.
And I know you're going to be talking about alternatives.
Yes.
So, for example, finasteride. But somebody put in the chat here that one that's used in Europe sometimes is, I'm going to hammer this pronunciation. Calmutide. Sorry?
Yeah.
Bicalutamide.
Bicalutamide. There are some medications that are available in Europe that are not available in the United States. And I believe that is one of them. There are a couple commonly used medications in Europe for trans folks are not available in the United States. Another one I think is a progesterone formulation. So yeah. I'm going to share with you that when I transitioned many years ago, spironolactone was not part of the regime. And you can feminize without it very effectively, just using estrogen. This is just an added tool. I think it helps you get there probably faster with the combination, blocking it plus adding the estrogen than it is with just kind of overwhelming your system with estrogen. Just my opinion.
Yeah, and another one that just came up was cypretone acetate.
Acetate, yep, that's the other one.
Yep.
Cyproterone, I think it's called. Yes, cyproterone. If you're a provider and you decide that Spiro is not the best choice, you'll probably be prescribed either finasteride or dutasteride. These names kill me. They essentially work the same way. They're considered 5-alpha reductase inhibitors. They don't actually stop testosterone, but they stop its conversion from testosterone to dihydrotestosterone, which is like the subunit of it that kind of does the most damage. Finasteride, many of you might know that as Propecia, and that's used to treat hair loss. And also it's used to treat benign prostate enlargement. So you can start that at about 1 milligram a day, increase it to about 5 milligrams a day. And the other one, dutasteride, is also known as Avodart. And again, used to treat hair loss and to treat BPH or benign prostate enlargement, usually given at about 0.5 milligram a day. They are weaker than spironolactone. But they have fewer side effects. So that's kind of the trade-off there. So again, life is full of trade-offs. So, less effective, but safer.
Yeah. And I think that's something that comes up a lot, right? Is that these, you don't necessarily need testosterone blockers in order to achieve feminization. And I know there's a lot of controversy in trans femme circles right now in terms of, do you even need a testosterone blocker at all? And I think the answer to that is, and correct me if I'm wrong, but is that you don't. You just need to have more patience.
Yes.
Yeah.
I agree with that, Corinne, 100%. As I said, in the long history of treating trans people, spironolactone is a fairly recent development, and people were successfully transitioning for 30 years before somebody got the bright idea to use this. But I think what you said is absolutely true. It does take a little bit longer to kind of block the testosterone.
So a couple more kind of quick questions here, and this just allow you to catch your breath too. But is that so? What is the difference between finasteride and dutasteride? Is there a significant difference?
No, they are the same class, two different brands, the same classification of medication.
Okay, so it's like Advil versus Motrin.
Yes, exactly. It's not like Advil versus Tylenol. It's like Advil and Motrin, correct?
Yeah, and then another person asked about removal of the testicles, so orchiectomy, which I can say is awesome.
Yeah, you can speak to that. I mean, that obviously would eliminate the need for any type of testosterone blocker, and you could go merrily on your way with estrogen.
Yeah.
Correct.
And it also has gotten me off my potato chip habit.
I would hate to lose potato chips. Anyway, so the last medication I'm going to talk about in this little section here is progesterone, and I consider progesterone an enigma because when I was practicing nurse midwifery, progesterone is like poison to women, to cisgender women. In cisgender natal women, progesterone is the hormone that causes PMS. And curiously enough, it's the active ingredient in birth control methods. So in trans women, it can be taken as a pill or applied as a cream. As I said earlier, some people are doing it rectally as well. They believe that taking progesterone provides benefits with regard to improved mood and libido or sex drive, higher energy levels, enhanced breast development, and encouraging the redistribution of body fat. So it supposedly has all these benefits, but I can tell you that if you search the medical literature for this, there are no scientific studies that support this. But it's kind of like an anecdotally thing. So for instance, at one point, I thought my libido was down in the dumps. And so going to my provider, let's add progesterone. I don't know that it made a big difference. It certainly doesn't seem to have a bad effect. I don't know if anybody wants to share their experiences on chat if they've used it. There is a good sense of thought that it does aid in fuller breast development, but it has to be done at a certain time, like not from the beginning. Start with estrogen and then add progesterone at some point. At any rate, it should be taken at bedtime. It can cause a little bit of dizziness. An oral progesterone, a common one is Prometrium, and commonly they either prescribe 100 or 200 milligrams a day, taken at bedtime. Another oral form is Provera or medroxyprogesterone acetate. It's in a smaller dose, same medication. It can be used as a compounded cream too. There are some compounding pharmacies that make progesterone cream, and I believe there might be a brand name of it available as well. There's another form that's intramuscular injection called Depo-Provera or metroprogesterone acetate. That's the 3-month-long birth control that women use. It's less commonly used in trans folks. And it generally, the side effects from the Depo-Provera injections are not great. So I don't recommend it, and most providers aren't prescribing it. Some trans women use progesterone sublingually as well, letting it dissolve under the tongue. But again, I mean, if it wasn't formulated to break down that way, the same with the rectal use, it may not be worth it. Take it orally as prescribed, or use the cream if it's available. And you should be okay. I've been on and off it over the years. I don't have any strong feeling one way or the other. Some trans women swear by it, in which case go with it. There are very few side effects, so.
Yeah, I know I can say for myself that, so I'm on progesterone, and I'll say that, and I'll disclaim this as saying is that, these effects might have happened anyway. But when I went on progesterone, not testosterone, thank God. But when I went on progesterone,
I went on testosterone.
I used to be on that. But when I went on progesterone, that almost immediately I gained 5 pounds. I mean, like it felt like within a week. And it was really about like 3 weeks later that I realized that all of a sudden I was like eating a lot. And I didn't even know I was doing it. So that, and I've heard that as a side effect. And then, and I did get some more breast development, whether or not that was really attributable to the progesterone or not, who knows?
Yeah, again, it's, I agree with that. You do tend to put on weight from it, I believe. And we certainly know that's the fact in natal women or cisgender women. Causes all that bloating and discomfort. So that's the culprit. But again, I think somebody messaged that they use 200 milligram at bedtime. That's perfectly fine dosage and you're taking it at the right time, perfect.
We have a question here also about energy loss from using T blockers or anything else for that matter.
Yeah, we're gonna talk a little bit more about that in the upcoming slides. I'm glad you brought that up. So stay tuned, and if I don't answer that question, shoot it at me again.
Great.
Because this section is what can I expect from feminizing therapy? So, you know, as your therapy progresses, you can expect some significant changes to occur. And generally, we think of them as falling into 4 categories: reproductive impacts, sexual and libido changes, libido being sex drive, your emotional state, and of course, your physical appearance. We're going to go into each one of these in a little more depth. Again, talk to your healthcare provider about these in depth if you need to. So the first change you probably notice from the estrogen is that your skin's going to become a little bit drier. It might feel a little thinner. It will soften. And these changes usually occur within 3 to 6 months after starting estrogen. Your pores may become a little bit smaller. In my case, it solved a horrible case of acne that I had been battling for years and years and years. Went away in months. You're going to have a little bit less oil production. Again, you know, that's what happened, and that's probably what cured my acne. You might find that you might need to use moisturizer a little bit more often on your face and body. And one caution is that for some folks, those of us fair-skinned Caucasian folks, sometimes taking an external source of estrogen increases your photosensitivity. So it takes less ultraviolet light to give you a bad sunburn. So be careful about that. And we should all be using, you know, sunscreen anyway, but especially if you're taking estrogen.
Somebody asked if it, somebody asked if it reduces redness at all. Well,
it depends. If the redness is caused by rosacea or something like that, probably not. But honestly, you know, it's possible. You know, you never say never that you know could never cause redness, but or reduce it, but most likely not. Good question though. That was and I promised to research that a little bit more. So thank you. You're also going to notice that the odors of your sweat and urine will change a little bit too. You might even sweat a little bit less. That's nice. You might find that your sense of touch, things feel different, including how you sense changes in temperature. A lot of us can testify to that. You may become either more heat intolerant, you could become more cold intolerant, in which case you want to go to Hawaii, or you can be intolerant of swings of temperature, you know, and a little bit more sensitive to that. So that's, you know, that's par for the course for a lot of folks, for a lot of trans folks. You might notice that your nails become a little brittle as well. And, you know, there's not much that can be done for that. You know, your dietary supplements may or may not be of benefit there. Keep them nicely filed and trimmed so you don't snag them on things. And now, of course, what we all want to know about is breast development. So you're going to begin to develop small buds beneath your nipples. They feel like little hard spots under there. They might be slightly painful to the touch, but you will find that over time that super sensitivity and painfulness kind of subsides. But at first, it's like one of the first signs that estrogen's really working and doing its thing. You're going to feel this, and not unpleasurable in some cases. It's important to note that breast development varies from person to person, and that different individuals' breasts will develop at different rates. So just like a cisgender woman, full breast development can take several years. Generally speaking, it takes about 3 to 6 months for changes to start being noticeable, and the changes will max out in about 2 to 3 years of therapy. So after about 3 years, if you're not where you want to be, you know, you can consider breast augmentation or something like that. But I always say, you know, give it at least 2 years on estrogen before you make that decision, because that's generally about when you're going to max out. And while there's always exceptions to the rule. Most likely you're going to end up with an A or B cup, probably not much larger, although there are exceptions. And I always tell trans folks, if you want an idea of how big your breasts might develop to, take a look at your mom. Because you do share that kind of gene pool, and so that may have something to do with it.
There's a question about do breasts become off shape the older that you are when you start HRT?
Yeah, I've heard that too, but I'm not sure that that holds true. What I have heard, though, is that if you introduce progesterone into the mix too early, that's when this kind of misshapen kind of breast development occurs, not so much the age at which you start. Again, that's a very good question. So, weight. Your body's going to begin to redistribute your weight. And this is usually noticeable, say, in about 3 to 6 months of therapy. The changes can keep happening for up to 5 years. In most cases, fat is going to collect around your hips and thighs. The muscles in your legs and arms are going to become a little less well-defined. Unfortunately, if you already have belly fat, your hormone regimen is unlikely to have a good effect on that in terms of reducing belly fat. Some people may gain weight when they start hormone therapy. Some folks lose weight. Again, the hormone isn't the only player in this equation. It's also your diet, your lifestyle, your genetics, the muscle mass that you start with. So all those things play a part in this. I can share with you that when I started hormones in about 6 to 9 months, I got awfully clumsy. And I don't know if anybody else ever experienced that, but I sure did. And what I think it was, I was tripping over furniture and just like being a total spaz. And I think what was happening was that my center of gravity in my body was redistributing itself from the shoulders down to the hips, and my proprioception didn't know what to do with that. So like for a while I was a complete idiot. I couldn't walk and chew gum at the same time, but that passed with time. You kind of get used to those changes. Will it be harder to lose weight? Generally speaking, yeah, because you're taking estrogen, and estrogen likes to attach itself to fat cells. And that's why some really extremely skinny trans women have a hard time starting to see those effects, because there's no storage of estrogen in the body if there's not enough fat cells. So as you kind of gain fat cells, those cells will hold on to estrogen and kind of like excrete it gradually in addition to what you're taking. So your endo said, there was a question, I'm going to jump in here, Corinne, because I think I'm seeing them too now. Opposite about progesterone, unless it is started before estradiol. I will check into that. I don't want to disagree with anybody's provider. But I can check into it, and I would ask you to kind of ask your endo the same thing. Is it really before or after when the bad effect is? Most providers don't generally start trans women on progesterone right away.
Yeah, and I'll just jump in there to let you catch your breath too. Is that there are very, very few long-term studies or even short-term studies that really talk about and speak to the impact of estrogen or feminizing therapy, or for that matter, masculinizing therapy for trans guys. And so the science isn't settled, and so much of this becomes based on anecdotes and on an individual provider's kind of personal experience with patients. So what I'll say is that based on from what I've seen is that the providers that serve lots and lots of patients. So I know providers that serve 1,000 patients, and I know providers that serve a dozen. And certainly the impact of the veracity of the opinion of a doctor who probably serves 1,000 patients is likely a little stronger than somebody who serves a dozen. but everybody's experience is different. And again, it gets back to everybody's body is different too.
Yeah, and I'm going to echo what you say. So like every few years, I have to revise my course, and I have access to the most wonderful medical library in the area. And so I pour over the literature as it comes out. And what Corinne said is absolutely true. There's not a lot. And so the good part is there's a lot more coming out as more and more folks are treated and more providers take an interest in doing this kind of research. But that's part of my mission in life, is to comb through the published journals and see what's out there and the best practices. Somebody texted about effects of meds on blood pressure. I will tell you that taking estrogen, progesterone, I'm going to leave out spironolactone for now. Taking those two generally does not have an effect on blood pressure one way or the other. It should not increase blood pressure. On the other hand, if you have high blood pressure, it should not lower blood pressure. It should be like a null thing. Because a testosterone blocker like spironolactone, that's used to treat blood pressure. And so, yes, that can actually drop your blood pressure because that's what it does. And that's what it's prescribed for most people that are not trans. So I don't know if that answered your question, but the hormones themselves should not increase blood pressure. Good questions. I love this. Thank you for the dialogue. So muscle mass, I spoke briefly about that a little bit ago. Over time, your muscle mass and strength will decrease. You'll probably notice this in about 3 to 6 months, and it usually levels off in about 2 years. So if you want to maintain muscle tone, exercise regularly. Otherwise, you're going to have to get somebody to help you open a pickle jar or help you move when the time comes. So one of the really nice benefits you'll be excited about is that the fat under your facial skin is going to increase and shift, resulting in a more female appearance over time. It's a subtle change, but those people that are around you might not notice it from day to day, but it will change, and people that haven't seen you in a little while will notice the changes in your face. It can take about 2 years for these changes to take place. So if you're considering facial feminization surgery, again, I would say, give it a year or two to see how the effect is before you take that step. But again, I've known trans women who've led with facial feminization surgery before even taking a drop of hormone. So to each their own. I don't think there's a hard and fast rule there. So one thing that won't change, unfortunately, for me is my voice and your voice. But the good thing is there's a number of smartphone apps that you can use and online courses you can take that'll help you practice techniques to make your voice sound more feminine. And many trans women engage the services of a speech therapist or a speech therapy clinic to help with this process. I believe, Corinne, there's one at Moravian College, and they're doing some work with trans women.
Yeah, so I guess the first thing is that we have a provider who's a voice therapist coming in April to one of these seminars who will be talking about voice therapy. And then actually she is the leader of the voice therapy department, I guess it is, at Moravian University. And we've worked with them, and every quarter they provide free voice therapy services for trans people every quarter. So you can find information usually about that on our website or if you subscribe to our newsletter. And I noticed that Kate mentioned a couple of the apps that are available on smartphone as well. So a lot of people I know use those.
Tools and voice pitch analyzer. I have voice pitch analyzer. I don't like to look at it. So interestingly enough, when I started working in the medical profession, having this kind of male type voice actually kind of worked in my favor sometimes, believe it or not, because, it's a sexist environment out there. And if you can get down and talk on the level with physicians and other providers. They take you seriously rather than squeaking. And, so anyway, I digress. And again, there's actually surgical procedures that can be used to change the pitch of the voice, but those are way beyond the scope of what I'm presenting tonight. So we will move along. Let's talk about hair a little bit. So one of the benefits is that the hair on your body, including your chest, back, arms, and legs, over time it'll become finer and grow in at a slower rate. In some cases, it can become virtually invisible to the naked eye. And don't expect that right away. That's an effect that you're going to see in 6 to 12 months. But the hair is unlikely to go away altogether, though. So keep in mind that all women have body hair. So you can choose how you want to deal with yours. As a nurse midwife, I've seen it all. But facial hair, that reacts a little bit differently than body hair. And while you might find that it might thin a little bit and grow in a little bit slower, facial hair will not likely disappear, and it won't diminish to the extent that you hope it will. So unless you really want to continue shaving on a regular basis, it's the usual undertaking some laser and or electrolysis treatments to permanently remove your facial hair. And last but not least is the hair on your head. So it may change in terms of texture. Over time, it may become a little bit finer. But any balding that you have incurred in the past should slow down or stop. But once you've lost your hair, it's not likely to grow back. So the good part is the hair loss sort of stops, but the regrowth isn't there. So again, oops, I kind of jumped a little bit, excuse me. Many trans women seek out alternatives such as hair grafts or transplants or wigs or extensions to help with that. And a good hairstyle can work a lot in your favor. So find a good hairstylist. We're going to talk a little bit about emotional changes. I'm not a real touchy-feely person, but I'll do my best to shoulder through this part of it. You're going to go through what's like a second puberty, and it's a real roller coaster of emotions. So, show of hands, did you ever cry at movies when you were in full boy mode? Nah, and now it's like at the drop of a hat, it's like, so that's part of the changes, you're going through kind of a second puberty, and this is it's to be expected. You might find that you become more emotional. It can result in changes as to the way you relate to others. Your interests and pastimes, the things that interest you, might kind of shift a little bit over time. And there is that kind of pressure that some of us we deal with our whole lives. It's kind of like girls don't play with trains, but a lot of us like to play with trains. So, girls aren't amateur astronomers, but some of us are amateur astronomers. So fortunately, society's moving in a better way there. But, you might find that you suddenly take an interest in sewing or cooking, and that's cool. Traditionally feminine pursuits, I suppose. But explore those thoughts and feelings. And again, I'm a person that's all for the informed consent model. We tend to think of therapists as gatekeepers to our care, but I think without a good counselor and somebody that you can bounce things off of from time to time, I think that really helps in a transitioning person. So I'm all for that type of therapy. It honestly saved my life. They made me look at options that I hadn't looked at before. They had me look at, the way I looked at a world in a different way. And I think if it did it for me, it could do it for most of you too. And sometimes you just have those horrible, horrible days, where you're being misgendered all day long. And it's just really nice to talk with somebody about that.
Yeah, so very quickly, so a couple of comments in here. So one is just sort of back to physical changes. We'll back up just for a second. How about changes to the lips and to, I guess, your mouth?
Not so much.
Okay.
We did talk about fat distribution in the face, but it's not likely that enough of it would migrate to make a big difference. If you're interested in that kind of change, there's lip lift procedures that can help. You can have fillers. Some folks try with fillers first to see what the effect looks like before they actually go under the knife. All those are options.
I think that as your face changes, though, right, the appearance of your lips may change a little bit. So, I think that kind of the general standards of care are that, try HRT for a couple years and then make your decisions, generally speaking, on surgical interventions or fillers or plumpers or things like that sort of after. Yeah.
Well, now that I'm a woman of a certain age, I will tell you that your face changes due to age too.
Absolutely.
The underlying collagen starts to break down and you get the laxity. I never had this before, and we're all going to see those changes should we live long enough. I know.
Yeah, and another person, and I think that this is really just a good time to kind of stop and maybe have a little bit of a conversation about informed consent versus following the W path. And I know this is a conversation that we have in the support groups that we sponsor a number of times a year. We have these conversations. And, again, I'm a huge believer in informed consent. I've known that I've been a person of trans experience forever, it feels like, although I didn't always have the words to describe it. And so when somebody goes into an informed consent clinic, like locally we have comprehensive health services, and they are an informed consent clinic. You go in and you speak to them for usually an hour or two. You might meet with a social worker, you meet with your doctor. The doctor will explain exactly what the potential effects of HRT therapy are, and you can walk out a couple hours later with a script for your HRT. What a lot of people don't understand, though, is that beyond the benefits of a therapist helping you to navigate your coming out process and navigate how, how to be a disinterested third party to help you understand, how you're kind of working with society in this new role. Surgeries, on the other hand, still require letters. And so, and that's because the insurance companies are driving that process. So surgeons don't work under informed consent. Surgeons work under the WPATH standards. And so if you're thinking about ultimately getting surgeries, and so for myself as an example, for a long time, I didn't have any intention of having surgeries, but I decided not too long ago to have an orchiectomy, and I needed to have letters for that. And if I hadn't gone to visit therapists over the years to get those letters, I would have had to sort of start over, and that would have delayed those surgeries. So informed consent is a wonderful model, but if you think that surgery may be in your future, even if you're not sure, it may be worthwhile still engaging with a therapist.
I agree with that. When you step back and put yourself in the provider's seat, especially if you're a surgeon, you are going to do a procedure on a person that's going to permanently alter not only their body, but how they're perceived by the world and how they relate to the world, changing into a different gender, as it were, even though they may have been living in that gender for umpteen years. From a provider's point of view, that's a heavy responsibility. And what providers like to have is consensus that, as a provider, I might think I am doing the right thing. Would somebody else agree with me? And, we can get into philosophical discussions until the sun comes up. What would a provider do if a person came to them and said, I always wanted to be an amputee? I want you to remove my right leg above the knee because whatever. You have to say, well, a lot of us kind of think that's creepy, and there have been surgeons that have done that. Right or wrong, I personally believe that that's naming somebody, but again, I'm not in that position. So I'm just saying, counseling is always a good thing, and having somebody to bounce things off. I personally agree that yes, Hormone therapy, should you decide it's not for you, none of the changes are permanent. You go off the hormones and eventually, except perhaps for reproduction, and we'll talk about that in a minute, it's considered basically, I won't say harmless, but low risk. And so, if you understand what you're doing, and I understand that, we're good. We don't need a therapist in there. But once we start cutting on a person's body, we've crossed a threshold. That's just my own opinion, my own opinion. So again, I'll move us on otherwise.
And then just one other kind of
Sure.
comment real quick, because I don't want to slow you down now, but is that somebody said that, I read that HRT makes you feel better mentally and it lowers your dysphoria.
I think so.
I know for me it did, right? So, what it did, and again, it's all anecdotal, but is that in my case, certainly it felt like my brain was no longer fighting with my body. And it just sort of took my level of tension down, a few notches. So I went from being on 11 to being a 4, right, in terms of my my level of dysphoria. And it sounds like a lot of people on the meeting here are saying the same thing.
Absolutely. On a personal level, it saved my life. Absolutely. It made me a person that I could live with. Yeah.
All right, let's move on.
Okay. We're going to talk about sex and libido changes. This is the best part, right? So soon after you begin your feminizing treatment, usually in about 1 to 3 months, you're going to notice a decrease in the number and frequency of the erections that you have. Your testicles will also shrink significantly. That usually start in about 3 months and continue on for about 2 years. Erections will become less firm. You may lose the ability to penetrate your partner if that's what you're doing. If erectile dysfunction occurs and you have and your partner has a desire for erections, there's no contraindication to using something like Cialis or Viagra. Again, it will likely work. For an overall low libido, you could try reducing the dosages of anti-androgens or estrogen for that matter, but most of us don't like to do that. Some providers will add progesterone in an attempt to boost the libido a little bit. That's a possibility as well. You might find that you get erotic pleasure from different sex acts. Orgasms are going to feel a little bit different, but just as pleasurable in the past. Your ejaculations are going to change. Over time, it'll become, the fluid will become more clear, less thick and white, more mucousy, and there may not be any fluid discharge sometimes. And as your sexuality changes, don't be afraid to explore, experiment, involve your sexual partner if you have one, but always be safe. And when we talk about sex and reproduction, it's kind of hard to divide out the two. Some people are going to maintain a sperm count while on feminizing hormone therapy. In most cases, though, you'll become permanently and irreversibly sterile within a few months. So if you think you might want to parent a child in the future, you should talk to your provider about preserving your sperm in a sperm bank. It's not expensive. The upfront fee sometimes can be about $1,000, but for storing it a year, it's like $150 to $300. So one thing to consider. But if you don't want to become a parent, and since some trans women do maintain viable sperm, if you're having intercourse with a cisgender woman who could get pregnant, use birth control because that has occurred. General health feminization therapy is generally considered safe as things go. But with like any other medical treatment, you should be aware of the risks, get regular checkups, discuss any health changes with your provider. So let's look at some of the health-related factors that you should be aware of when undertaking feminizing therapy. So a lot of people are concerned with blood clotting. Estrogen does make your blood a little bit prone to coagulation, which can result in blood clots. or strokes or pulmonary emboli. The risk for clots is considered to be slightly elevated, but minimal. And again, if you're on the right kind of estrogen and avoiding the bad kind of estrogen, which most providers are really tuned into, you should be okay. Again, the risk for clotting is elevated if you're using tobacco and you're over age 35. The good news is that no matter, cancer risk. So what I like to tell providers is when you're taking care of trans people, pay attention to the organs they have, because that kind of guides your healthcare overall. So if you have breasts, whether you're male, female, trans, whatever, look after the breasts. Be sure that there's no chance of breast cancer. If you have a prostate gland, get that kind of thing checked after. Whatever you have, check it. Trans men, if you still have a cervix, uterus, pap smears, that kind of thing, always a good idea. Whatever medication you're taking, monitor that. So I think we really do need a better focus. And I think my retirement focus is going to be long-term healthcare for trans people, because a lot of us are getting to that age. And there really isn't a lot of research on this yet. And that's where I think we should be focusing. So cancer risks. There's not a lot of research again on this, a little bit of here and there that you can pick up. Most indications are that your risk of prostate cancer is reduced, actually, because the medications we use to treat prostate enlargement, prostate cancer, are estrogens and anti-androgens. And so you're on those already. So prostate should not be a problem, but it's important to get that checked. You want to get a PSA once in a while, maybe a digital exam, although that's kind of like not as good as the PSA test. So as long as you have the prostate, check it. And then breast cancer. What is the risk of breast cancer? Again, there's nothing in the literature. We think that your risk of breast cancer is the same as a cisgender female. And again, we do know that it's genetically, there's BRCA genes that you can be tested for, whether you're prone to it. But just by fact of being on estrogen or feminizing therapy doesn't increase your chance of cancer. That's pretty well established. Does that mean you shouldn't screen for it? Absolutely not, because men get breast cancer, cisgender men. So we all have breasts. We all should check them. Again, a regular PSA, prostate health checks, and breast cancer screenings after you've been on estrogen therapy for 2 to 3 years. But at least if you've never had it, by the time you're age 50, you should probably have your first mammogram. And Corinne can tell us all about mammograms.
Got one today. So it was the highlight of my afternoon. And so somebody asked a question about, if you're getting surgery, your surgeons ask you to be off your HRT for a few weeks beforehand. Because of the risk of clots, and they're wondering if that's a misconception.
Okay, this is walking into a minefield. I'll tell you a story. Okay, can I tell you a story about my midwifery day, my nurse midwifery days? All women coming to the hospital in labor are kept NPO. In other words, while they're in labor, we don't feed them. They can't take anything by mouth. Okay? They can get ice chips, something like that, but no solid food or anything for the course of labor. Why? We do that because they might need anesthesia. Okay? Okay, so if women get anesthesia, 99% of the women in labor will get an epidural, which has no effect on things. 1% of those women might end up going under general anesthesia for a complication of childbirth. Okay, so now we're down to like 1% of 1%. A percentage of those women who get general anesthesia for an emergency situation might aspirate. Again, that's about 0.1% of women getting general anesthesia for any reason at all. So because of that 1 in 1,000 chance that a person could have a bad outcome, nobody gets fed in labor. So I think the same thing is at play here with estrogen prior to surgery. There's a theoretical risk, yes, that you could be more prone to blood clotting. Has it been well documented in the literature? No. Again, what I always tell people is, they're not going to test you when you come into surgery as to whether, there's no way of telling if you've taken estrogen the night before, the week before, 2 weeks before. They're not going to be able, it's basically an honor system. So what I say there is, if you can live with the consequences, follow your ideas. What I can tell you though is it's always good to follow medical advice. And the other thing is that I mentioned earlier, if you've been on hormones for any length of time, the worst that you're going to get from withdrawing them for a couple of weeks is headaches and a mood swing. You're not going to become less feminine. You're not going to start growing hair like an ape. You're not going to, your penis isn't going to start getting bigger. All that stuff. So I think we make more of a big deal of it than it needs to be. So, my advice is go off of it for that a period of time if that's what your surgeon wants. And if you can't live with that, just tell them you're going off with it. And Corinne is going to edit this part of the talk.
She is.
Thank you very much, because I'm being really frank with you, and probably I don't know if I answered the question.
I'm sure that our insurance company would say that it's important to follow your surgeon's advice.
Absolutely.
So the next question was, if you have a situation with your BPH, is HRT going to help you with that?
Good. Particularly if you're using finasteride, you can maybe instead of the spironolactone, if you could talk to a provider and say, instead of that, can I go on dutasteride or finasteride? You would get added benefit. Estrogen over time will shrink the prostate. And so there's a very, very low incidence of prostate problems among trans women. And that's a good question.
Great.
Okay, so I think we're just about there, right? Needless to say, this is an exciting hallmark time in your life if you're starting feminizing hormone therapy. In most cases, it's safe, effective. It'll be a positive change in your life.